move on to our next session, that is a state-of-the-art lecture. And for this session, we have our two chairpersons, Dr. Manoj Chawla. I think sir soon, and Dr. Dharmendra Pachar from Ahmedabad. So over to you, Dr. Dharmendra Pachar.
Yeah, thank you, Dr. Snehalitha, for inviting me. And ladies and gentlemen, I welcome you all for the State of Art lecture. First lecture will be going to taken by Dr. Tirthankar Chaudhary. He is MBBS, MD, MRCP, FRCP, both London and Edinburgh. Postgraduate certificate in diabetes from London, specialist training in diabetes and endocrine from UK, senior consultant in diabetes and endocrine at Apollo Multispeciality, Kolkata. He has been examiner for MRCP UK. He has written book chapter on multiple book chapters in various textbooks, and he has on his name many publications. This will be a pre-recorded session. Would request RX team to please run the video.
A very good day, and I thank the organizers of Diabetes India for inviting me to speak this morning on a very interesting topic, ASCVD in type 1 diabetes. Now we must understand that our knowledge of incidence, prevalence, cardiovascular disease, and mortality is mostly an extrapolation of our knowledge in type 2 diabetes and cardiovascular risk. However, there is some fundamental difference between type 2 and type 1 in terms of ASCVD. In type 1 diabetes, chronic hyperglycemia, hypoglycemia, glycemic variability, along with the standard risk factor of dyslipidemia, hypertension, and even metabolic syndrome are important. But we have also understood that in type 1 diabetes, duration of diabetes, early onset diabetes, and women are more vulnerable. What is also interesting to know is that even in a good metabolic control, the chances of ASCVD in type 1 diabetes is twice that of general population. We have also seen from our experience and our knowledge of epidemiology of complicational Pittsburgh study that people who were born between 1950 to 1964 and those who were born between 1965 to 1980, it is the latter group that has the increased life expectancy of 14 years. Similar knowledge comes to us from Scottish data that tells us that type 1 diabetes loses a life expectancy of 11 years and 13 years for the men and women. So with this knowledge in the background, we are understanding the gray areas where the evidence does not essentially correlate with the outcome. However, we have got some evidence at the moment, both of clinical atherosclerosis and risk factor for preclinical atherosclerosis. If you look at the burden of type 1 diabetes, then it was 0.5% in 2016 in US adult population, but it has increased worldwide, and that is due to reduced natural selection and improvement in cardiac care or cardiovascular disease care and cardiac interventions. As I said, that Pittsburgh epidemiological study for diabetes complication shows that overall mortality reduction and significant improvement in life expectancy happened as our knowledge of cardiovascular risk factor and intervention increased. We still do not know that at what point in a child, or for that matter in a type 1 diabetes, to intervene with the cardiac drugs. We do not have enough evidence of their implications also in terms of long-term outcome. Total risk of CVD remains in type 1 diabetic patient more than non-diabetic patient. If you look at the data of 2016-17, and if you look at the mean age of population 28 to 44, then you see 16% had a history of CVD. You had 2% had a stroke. But if you look at the Indian data, then we do not have very good data follow-up in terms of what happened to the type 1 diabetes later on in terms of cardiovascular disease. There are some recent publications, of course, but what I'm referring to is that we have got one understanding that the risk of diabetes increases 3 to 18 times in type 1 diabetic due to cardiovascular disease in comparison to general population. Now the question comes, what happens if there is a chronic hyperglycemia? What happens is very simple, that when blood glucose or plasma glucose enters a cell, there is a stress of the endoplasmic reticulum. And this endoplasmic reticulum stress produces reactive oxygen species or oxidative stress. And they stimulate the cytokines and chemokines. And these in turn generate a cascade of inflammatory pathway, stimulating interleukin 6 and TNF alpha, etc., that ultimately lead to the endothelial dysfunction. If you look at the lipotoxicity or adipocyte, when there's too much of ectopic fat and the adipocyte gets hypoxic death, they also become a center of cytokines and chemokines. They also contribute to the inflammatory pathway and lead to the endothelial dysfunction. These are the studies that have made us wiser in terms of clinical atherosclerosis in type 1 diabetes. It talks to us about the ASCVD in terms of incidence. It talks to us in terms of prevalence, cardiovascular disease, and mortality. If you look at the Jocelyn study, they had a small number of patients, 292. But when they looked and followed it for 20 to 40 years, they had cumulative mortality risk, which is far higher than the general population. If you know the Wisconsin epidemiological study, they had got two groups. One was the younger age group, had almost 1,200 patients who were on insulin and diabetic. They had a greater risk. If you look at the right side, I will show you the data. If you look at the younger onset versus the older onset, then you will find the ischemic heart disease or standardized mortality ratio is far higher in the younger group, those who are on insulin less than 30, than on the older onset. If you look at the Pittsburgh epidemiological study, it was a cross-sectional study. Again, standardized mortality ratio was much higher in men and women in comparison to the general population. Eurodab is another study that tells you the CVD risk of 9 and 10% prevalence in men and women. But more interestingly, Eurodab also tells you that if you are between the age of 15 to 30, the risk of cardiovascular disease, the cumulative risk is 6%. But if you survive between the 45 to 60 years, it goes up to 25%. If you compare the EDC and Eurodiab, then what we find is that they actually match in terms of outcome. But when you compare the DCCT versus the EDC, the Pittsburgh Epidemiological Diabetic Complication Study, what you find is that the intensive control group is much better in terms of cardiovascular risk in comparison to the conventional group. What I'm trying to say is that Framingham study showed you CAD of 35%, much higher than the non-diabetic population. Pittsburgh Epidemiological Study again showed you that the incidence of major CAD, type 1 diabetes aged between 28 to 38, was 0.98% per year, surpassed 3% per year after the age of 55. Eurodab IDDM complication study, it shows that had 3250 number of type 1 diabetic patients and prevalence was 9% to 10%. But if, as I said, that increased with diabetes at 6%, the CVD prevalence to 25% if they survive longer. UK General Practice Research Database is a good because they had more than 7,400 type 1 diabetic patients. And if they looked at the mean age of 33 plus minus 14, the diabetes duration of 15 plus minus 12, reported that CVD events occurred about 10 to 15 years earlier in type 1 diabetic patient than non-diabetic group. So during a mean follow-up of 4.7 years, the hazard ratio was much more in terms of type 1 diabetic patient. If you look at DCCT, EDIC, EDC compare, as I said, the intensive group of DCCT, EDIC had lower cumulative incidence of cardiovascular disease than conventional treatment group. So what was the difference? The blood sugar was better controlled, but was significantly higher in the conventional group where the blood sugar was not so intensively controlled. If you look at the Swedish National Diabetes Registry, they also concluded that early onset, women, and poor glycemic control affected the outcome. Type 1 diabetes before 10 years. This is interesting. Those people who had diabetes type 1 before 10 years, they had the risk of 30-fold increased risk of CHD and AMI. And women displayed a 60 to 90-fold increase in terms of acute myocardial infarction. And of course, the women are affected more than men. And CVD prevalence depends on diabetic duration, glycemic control, age of patient included in the cohort. This has events happened 10 to 25 years earlier, ladies and gentlemen. So now we come to preclinical, subclinical atherosclerosis. The big question is, you have got a type 1 diabetic patient in a clinic. So how do you assess? What we say is that if you find an ankle brachial pressure altered, and if you find a coronary calcium scoring abnormal, then there is a reason to look at the luminal stenosis. So what are the parameters you are going to look? CIMT, that is carotid intima medial thickness. If it is more than 1 millimeter, if you do a coronary calcium score and it is more than 400, extensive evidence of CAD. Of course, 300 to 400 does not mean that they are not risk, but 400 is very convincing. And of course, coronary computed tomography and angiography, it is a confirmed study to look at the luminal stenosis. These can identify your patient at risk. I'm talking of preclinical atherosclerosis. However, as I told earlier, altered ankle brachial pressure or coronary calcium scoring is high is a reason for you to investigate further. Now, if you look at endothelial function is altered, even at a very early stage in type 1 diabetes, we know that. A meta-analysis of 90 studies confirmed what? That there was significant greater carotid IMT. And if you can do further these studies available, then endothelial-dependent flow-mediated dilatation was reduced. There was significant increased velocity between carotid femoral pulse wave, and there was decrease in the dilatation mediated by nitrates. These are some of the things that can give you an insight on a preclinical atherosclerosis in type 1 diabetic patient. I think it is very important reason to investigate and pursue our CVD risk in type 1 diabetes, because we know that you can actually prevent and postpone death. The pathophysiology, as we know, the etiopathogenesis, factors in type 1 diabetic patient. There are conventional risk factors, hyperlipidemia, hypertension, smoking, etc. But we also know that there are hyperglycemia, hypoglycemia, glycemic variability, metabolic syndrome, insulin resistance, albuminuria, age, gender, duration of diabetes, and even exercise. I want to remind you about the steno type 1 risk engine. If you look at the steno type 1 risk engine for type 1 diabetes, a CVD risk, then you know that they take into consideration your HbA1c, they take into hypoglycemia, they take ethnic origin, they take your even exercise, alcohol, so age, gender. So they are quite comprehensive, and they actually estimate the risk better. Now, if you look at hyperglycemia, as I said earlier, that oxidative stress, protein kinase deactivation, non-enzymatic glycosylation, these are important, and even 1% risk in HbA1c is associated with 6.4 increase in terms of coronary stenosis. The risk of death from CV causes in type 1 diabetes with HbA1c less than 6.9 is twice that of normal population. That makes you worry that even in a good metabolic control in type 1 diabetes, you have got twice the risk of death in terms of cardiovascular disease. But if you have got more than 9.7, then you are at risk of 10 times. Therefore, it is important that we understand that we need to intervene very seriously. And we know that the 17 years follow-up of the conventional group, we know versus the intensive group, you can reduce the CV events, you can reduce non-fatal MI, and the combined endpoint of stroke, MI, CVD can be reduced. Hypoglycemia, as we all know, can cause subclinical inflammation, endothelial dysfunction, thrombosis, ischemia, autonomic dysfunction, arrhythmia. Effects can promote atherothrombosis, cardiac ischemia, and cardiac repolarization. But what we don't know is that what is the exact correlation between each of them to the generation of ASCVD or as a risk factor for ASCVD in type 1 diabetes. But what we know for sure is that the recurrent hypoglycemia is established as a cardiovascular risk. Therefore, it is important to prevent hypoglycemia. And average type 1 diabetes, as you know, even if you leave aside the brittle diabetes, have averaged 2 minor hypoglycemias per week or even in 2 weeks. So we need to get the CSE score done and be more aggressive. Insulin resistance and metabolic syndrome, if you look at the DCCT study, demonstrated that intensive therapy was correlated, and excessive weight gain, this is in comparison to a general thought that all type 1s are thin. Insulin-treated intensive group did show evidence of metabolic syndrome and insulin resistance. Abdominal obesity is independently associated with CV complications that we already know. Lean type 1 diabetes present more insulin resistance than matched control subject. These are some important issues that we know. Dyslipidemia, this is our, as we know, is a standard conventional risk factor. Now, important is that how do you treat? Thumb rule is that anybody who is having an LDL less than, should be have a HbA1c less than 100. Now, any atherosclerotic risk should have less than 70. We also know that ADA tells you somebody who is over the age of 10 years and has no atherosclerotic risk factor, you should wait till 160. But of course, any atherosclerotic evidence less than 100, I think it is very important as a thumb rule to keep it below 70. And if it's more than 10 years of diabetes, then of course you can classify them as high risk, moderate, or at risk. Hypertension, again, our aim is to keep less than 140/90. Ideal should be probably 130/80. But a lot of studies, Eurodiab and DCCT has all shown that a good blood pressure control can affect the outcome. Diabetic kidney disease, as we know, the albuminuria is the first evidence of endothelial dysfunction. Therefore, after 20 years of disease duration, 29% of patients with childhood diabetes and nephropathy will present future CAD. So microvascular complication is a risk for macrovascular complication. So if we find somebody with albuminuria, then we should be very alert in terms of the cardiovascular risk. CVD prevention in type 1 diabetic patient, hyperglycemia, hypoglycemia, glycemic variability. CVD prevention in type 1 diabetes, maintaining optimal glycemic control in long term is mandatory, and disease decrease the macrovascular event, short diabetic duration, no previous CV event, and long life expectancy. A target of achieving HbA1c less than 70 is appropriate with the advent of course, insulin pump, multiple insulin injection. We can actually do a better glycemic control. More type 1 diabetes should be treated with intensive insulin regimen. We still unfortunately find that both monitoring and insulin regimen are less than expected. If you look at the dyslipidemia treatment, then of course there are guidelines you can go through. But of course, as I said, my thumb rule would be less than 70, but without atherosclerotic complication, maybe 100. Maybe children and adolescents have some more leeway, and you can go up to 130. But any evidence, they are often classified as high risk, moderate risk, and low risk. And in heart protection study, again, of course, lower age limit. And what they say is that if you have got type 1 diabetes, a reduction of risk that is proportionally similar to type 2 diabetes. And of course, in a prospective cohort of type 1 and no underlying CVD, lipid lowering theory was associated with decreased all-cause mortality. Recommendation, ADA guidelines, as I said, were less aggressive, but undoubtedly thumb rule is to keep it less than 70. Recommendations, you can go through an ADA, but both for blood pressure and statin, tight glycemic control, avoid hypoglycemia is what should be done. Type 1 is associated with 3-fold higher mortality rate. CVD is a major cause of this mortality. CVD risk remains high, even in well-controlled type 1 diabetes. Lifestyle intervention is important. There are concerns about CVR stratification. And of course, there are further research needed to clarify factors in premature CVD in type 1 diabetes. elucidate efficiency and age in which current CV medication should be used, and novel cardiac drugs. Just to leave you with a thought for my clinic patient who is a type 1 diabetic for 30 years, BMI 23, HbA1c 7.6, LDL-C 92, TG256, albuminuria, and on insulin pump. Now, stenotype 1 risk assessment is 10 to 20%. Therefore, I leave you with the thought of how aggressive you should be. I think investigation for luminal stenosis, better glycemic control, less hypoglycemia is my target. Thank you very much.
Thank you for the session. Dr. Tirthankar is here. Sir, we would like to take the question at the end of the session, and we will move towards the next session, which is going to be taken by Dr. Anil Boraskar. Dr. Anil Boraskar, sir, will speak on obstetric sleep apnea and diabetes. He is a honorary secretary, scientific section, Diabetes Association of India since 1984 till date. Member, Executive Managing Council, Diabetic Association of India. Member, National Academy of Medical Science, Fellow of Royal College Physician, London. Retired Chairman-elect of Southeast Asia region of IDF. He has been running his clinic, Diabetes Care in Mumbai, practicing since last 35 years. He has been honorary associate professor of medicine in Grand Medical College for 15 years, honorary professor of diabetology at All India Institute of Diabetes, Raheja Hospital for 13 years. He has been scientific secretary of Diabetic Association of India and many paper publication, oration, and what we need to learn is the wisdom from him. Over to you, sir.
Thank you very much, Dharmendra. Now, this presentation is going on for many years, and I was the one person who introduced this about 20 years back, that there is something known as obstructive sleep apnea, when people even did not know what it is. The point is that we saw many cases. You could not explain many symptoms. Next slide, please. And many symptoms. Next slide. Yeah. So what is obstructive sleep apnea? Repeated, partial or complete obstruction of the upper airway during sleep. It's a highly prevalent disorder which affects severe body systems. The most dangerous complications of the untreated OSA primarily include three body systems: metabolic, cardiovascular, and CNS. Now, you see, it's such a common thing that people are used to somebody snoring very loudly enough that, in fact, there are many divorce cases are filed because of snoring. But they never thought that snoring can have such a pathological effect. And all big snorers are not necessarily obstructive sleep apnea. And all obstructive sleep apneas do not snore loudly. You see, so you cannot really say that the snoring is the indicator of a OSA. Next slide, please. So snoring is such a common phenomena, and particularly with abdominal obesity and type 2 diabetes in India, snoring becomes a normal phenomena. Next slide, please. Yeah. Now, signs and symptoms are very important. Now, please pay attention to this. Excessive daytime sleepiness. Now, excessive daytime sleepiness in a big seminars like this is largely due to boring lectures. Loud snoring. Observed episodes of breathing cessation during sleep. Now, this is very, very important. The spouse comes and tells you, sir, he starts snoring, and suddenly he stops snoring and he just chokes and gets up with a frightening phenomena. So this is a bad thing, because that is a stage of apnea. There is a hypoxia. Abrupt awakening accompanied by gasping or choking, awakening with a dry mouth and sore throat, morning headaches, difficulty in concentrating during day, experiencing mood changes such as depression or irritability, high blood pressure, nighttime sweating, and decreased libido. Now you understand these symptoms are so common. All these symptoms are seen in chronic alcoholics. all these symptoms are seen with a chronic drug abusers. All these symptoms are seen by people who are undergoing a lot of stress, balance sheets, March end, people are trying to do a lot of adjustment, they can't sleep, lot of calculations. But if it is associated with the obstructed apnea, it's a serious matter. Next slide, please. Risk factors. What are the risk factors? Common as is obesity, increasing age, endocrine and metabolic, male genders, anatomical abnormalities of the upper airway, family history of sleep problems, alcohol and sedative use, and smoker. COPD, chronic smoker, chronic asthma, chronic obstructive lung disease. These are all risk factors. Next slide, please. What are the complications? There are 4 groups. Metabolic, cardiovascular, behavioral, and others. What are the metabolic? Most important, insulin resistance. Insulin resistance and elevated fasting hyperglycemia is a consequences of poor sleep, weight gain, nocturia, sexual dysfunction. Cardiovascular, many hypertension, rhythm abnormalities, atrial fibrillation, particularly left atrial enlargement, cardiovascular events, myocardial infarction in the sleep, and heart failure. Behavioral, cognitive, and memory problems. Many people, they say, I have not had a fresh sleep. I really didn't get a sound sleep, and somehow what you're telling me in the morning, I can't really comprehend, I cannot understand. Can you repeat it again? Even if you repeat it, he has a failure to understand. He says, when I try to read newspaper, I don't understand half of the things. I said, that is a normal pattern of newspaper. If you are wise, you will not read newspapers. All newspapers give confusing picture, confusing reports, but a sound person who's normally used to taking classes in the morning, he likes to brush up his academic tips. He says, I read it yesterday, somehow it's all confused. I said, did you sleep well last night? I said, that is a problem. Now, that's another thing, concentration difficulties. Now, concentration, in certain cases, your new learning process need a lot of concentration. Particularly new biochemistry, biophysics, synaptic junction, suprasynaptic, infrasynaptic, presynaptic, membrane transfusion, to all this read, and all the modern pharmacotherapeutics, when you try to read, particularly to teach the students, you feel, sir, this is ये नया कुछ समझता नहीं है. ये समझता नहीं because you are not slept well, and that's why people say you better sleep over it. ये जो है ना सब चर्वी चरण मंथन कर रहा है, you have a good sleep in the night, and tomorrow morning you come, and maybe the things will become very clear. So when the idiom is that to sleep over a problem, the problem becomes simpler. And others are excessive daytime sleepiness. And this is, believe me, this is a major cause of vehicular accidents in the United States. Daytime somnolence and nighttime insomnia. The drivers fall asleep, the truck drivers fall asleep while driving long distance. That's why now the highways are constructed that every 10 or 15 miles they have kept a bump. So the bumper wakes you up in case you fall asleep. The Chernobyl, the atomic reactors accident, and a space shuttle, the Challenger, the accidents were due to excessive sleepiness, fatigue-related accidents, and headaches. If somebody is complaining of constant headaches, there are 2 problems. One is number has changed, he's got a hypertension, and interrupted sleep. This is a cause of OSA. Next slide, please. Now, type 2 diabetes, what causes what? The cause and effect relationship, whether it's a bidirectional, whether OSA causes type 2 diabetes causes OSA. Let's go to that. Next slide, please. A number of studies, including longitudinal studies and meta-analysis, show that OSA is a risk factor for type 2 diabetes, independent of obesity and other risk factors. Independent, a thin fat Indian can also develop OSA, and that is a cause of type 2 diabetes. Next slide. Does diabetes lead to OSA? Yes. Meta-analysis has confirmed that the moderate to severe OSA is associated with greater risk of diabetes when compared with the absence of OSA. Next slide. The relationship is bidirectional. It is interesting that both OSA and type 2 diabetes are associated with a similar comorbidities, some of which include hypertension, CVD, dyslipidemia, and chronic kidney disease. Many of the ongoing trials are focusing on whether having both OSA and type 2 diabetes is associated with greater severity of a comorbid conditions compared to either one of them. So this is a very important study. The effect of OSA on type 2 diabetes. What is the effect? Next slide. Several cross-sectional studies have demonstrated a link between OSA and poor glycemic control, such as HbA1c, fasting glucose is high, variation in plasma glucose level, glycemic variability increases following adjustment for several confounding factors. Next slide. The severity and insulin resistance. Punjabi is a person who has won a lot of work, demonstrate that metabolic consequence and community prevalence of sleep disorder breathing after adjusting for BMI and percentage body fat. The increase in HI was associated with a worsening of insulin resistance independent of obesity. OSA is an independent risk factor. Southeast Asia study in Malaysia also concluded that insulin resistance and OSA. Next slide. Other study approach towards the patient with type 2 diabetes and OSA. How do you approach? Obviously, weight reduction is the primary thing. History taking, analysis of signs and symptoms of OSA, analysis of risk factors, examination of upper respiratory anatomy, particularly your adenoids, your upper pharynx, whether the tongue falls behind in the sleep. All this detailed analysis you must do. Next slide. Lot of importance to BMI. Diagnosis, very simple, type 1 diagnostic. Study a hospital lab. There are 12 lead EEG. It is costly, cumbersome, requires hospital stay for one night, requires a source-rich setup to conduct the study. But usually it gives you a lot of information about what is happening to his hypoxia, what is happening, the effect of hypoxia on the brain, what happens to alpha wave, beta wave, zeta wave, which is 12 lead EEG of the brain. That is the most expensive part in hospitalization. But the same thing can be duplicated at home, known as apnea link study, which can be done at home. Next slide. And that is quite practical. Next slide. Type 3, home-based cardiorespiratory monitoring diagnostic. 4 to 7 channels are increasingly used in practice by American Association of Sleep Medicine, as well as IDF has approved this. Next slide. It's a small calculator-like thing. Apnea link air study in diabetes patients. The IDF recommendations screening people with type 2 diabetes for OSA. The screening study used in which structure questionnaires stop bang. It's a structure question. It's a very important questionnaire that you have to answer, and it answers almost 50% diagnostics. Next slide, please. The question is very simple. In a simple language, it is written, and a person spends some time. He virtually gives you a diagnosis. Next slide, please. How do we measure? Now, AHI is apnea hypopnea index. There is apnea means total cessation. Hypopnea is a low number of oxygenation. 0 to 5 normal, 5 to 15 mild apnea, 15 to 30 moderate, more than 30 is severe. They need machines. Next slide. Treatment. CPAP is a gold standard treatment, I would say. CPAP is continuous positive pressure breathing. Along with CPAP, lifestyle modification, sleep hygiene, weight loss should be advised in all patients type 2 diabetes. Some other treatment options are dental appliances, surgeries in selected group, conservative measures such as alcohol cessation, smoking cessation, mild nasal decongestant so the nasal passage is open and you are able to breathe. Next slide. This is how the function of continuous positive airway pressure or a CPAP to put a nasal cannula, or there is something known as nasal pillows. You don't have to wear a mask, which is frightening. There are some nasal pillows, they give you positive pressure adjusted to your requirement of inspiration, expiration. There are autopaps, there are biovibes, and these are all self-adjustment machines available very nicely and definitely improves the quality of life. Next slide. Now these are the models. This is the most latest model. That is a bi-level. This is commonly used automatic CPAP machine. And this is a CPAP machine which is not variable pressure. This varies the pressure according to the obstruction. If the obstruction is less, it reduces the power of pressure. If obstruction is more, it increases the power. Next slide. Effect of CPAP on type 2 diabetes. Next slide. It reduces risk of incidence of type 2 diabetes. Incidence also comes down. Next slide. Treatment improves HbA1c. Definite improvement after CPAP. Next slide. Effect of CPAP on diabetes control. HbA1c fasting, plasma insulin and insulin resistance. Clear-cut evidence. Next slide. What about the diabetes complications? OSA is independent risk factor for hypertension and non-deeper phenotype BP. What are the non-deeper BP people? In the night, when you sleep, your BP must come down. We call it dipping. This dipping effect is not seen in diabetics. The night systolic pressure is 160. It doesn't come to 120. In type 2 diabetes, OSA treatment with CPAP has shown to reduce the mean arterial pressure, systolic blood pressure, and diastolic blood pressure. There's a beneficial effect in hypertension management in diabetes. Presence of OSA showed to increase the risk of stroke, coronary artery disease, and MI, and heart failure. CPAP has shown to delay or prevent the occurrence of CVD. Next slide. Microvascular complication, retinopathy, nephropathy, neuropathy, they all seem to be delayed, and some of them are even treated by use of CPAP. Next slide. Next slide. So, friends, I'm not here to promote the sale of CPAP machines. I don't have any agency or I get any cut from the company. But it is one single tool. In my case, I am a person who had a very severe sleep apnea. And I got everything making, means I am a home wicket for CPAP. I was weighing 123 kilos. Today I am 105 kilos. I lost 15, 16 kilos weight by sheer hard work, exercise and dieting. After that, my apnea has definitely come down. I hardly need to use the machine. My oxygen saturation improved. My quality of life is improved. I am a lot more approachable by my patients. I don't shout at them in the morning, early morning, late night. My students are quite happy with me because I don't scold them and I don't talk sarcastically, although they are a bunch of idiots, many of them. And I have developed enormous patience with everybody because I'm in complete state of peace to myself. I'm in a state of tranquility without any tranquilizer, without any alcohol, without any sedative. And only because I'm sleeping well, I'm breathing well, and I'm exercising well. There are three integral parts of health: exercise, nutrition, and rest. To follow these three patterns, you will not need a single medicine. Neither ACE inhibitor, not statin, not aspirin, nothing. But these are the features you do it seriously. One of them is sleep. Sleep is God's greatest gift to mankind. And that, if it is assisted with a tool without medication, what more do you want? Thank you very much.
Thank you, sir. And as I said, that's the wisdom we need to learn from Sri Boraskar, sir. Moving ahead to the next session, we do have Dr. Michael Hermann from Germany. He's going to speak on effect of lipid-lowering drugs and types of statin on SARS-CoV-2 infection and severity in diabetes. Dr. Michael is a senior consultant at St. Luke Academic Hospital, Brussels, and he has won the prize from Association of which do diabetes. He's a visiting fellow, Diabetes Research Laboratory, Oxford University. Desk is yours, Dr. Michael.
Thank you. Good morning, everyone. I will try to share my screen. So my topic today, I hope you are seeing my screen.
Yes, sir. Your screen is visible.
Excellent. So thank you very much for inviting me to share with you some results. This is a local study that we did in Brussels, trying to phenotype patients who became infected with SARS-CoV-2, and also to better precise the phenotype of diabetic patients who got severe forms. So this is a single center academic study, but we found some interesting results that I would like to share with you. So here are my disclosures. So as you all know, since the beginning of the pandemic, diabetes has been considered as a risk factor for severe COVID-19. But there is, on the other hand, no evidence that the fact of being a diabetic increases the risk of contracting COVID-19. Now, what is very confusing is that when you look at it, the two major risk factors for type 2 diabetes are the same as the two major factors for severe COVID, which is namely age and obesity. And the other problem is that factors predisposing to becoming infected or having severe COVID are usually subject to generalization that do not take into account the type of diabetes. And this is why we embarked on a study of both type 1 and type 2 diabetics to see what was common or specific to the different types of diabetics. And also, as you may know, because age and obesity are themselves contributing to affect glycemic control, especially the more obese you are, the lesser glycemic control you have. This is very confused and intricate. So what we did was to document the phenotype just prior to infections of a very well phenotyped cohort of mixed type 2 and type 1 diabetics that we saw over slightly more than 2 years, and then to analyze subgroups of specifically type 2 and type 1 patients. That's for the part becoming infected, and that we did the same for having severe COVID, analyzing in the global cohort of a mixed type 2 and type 1, and then in subgroups. Now, already here, we were not able to analyze a subgroup of type 1 diabetics with severe COVID because there were too little. We only got 5 patients with severe COVID with type 1 diabetes, so we couldn't even do that analysis, which itself is interesting. Altogether, we included 934 consecutive patients, about 2/3 of type 2 diabetics and 1/3 of type 1 diabetics. So here are the characteristics. If we take the overall cohort, I don't know if you see my arrow, but I hope you do. Overall, we got 20% of the overall cohort who became infected. And among those who became infected, another 20% got a severe COVID-19. Now, we define severe COVID as being admitted to hospital and or death from COVID. The study lasted more than 2 years, so over time, increasingly more patients became vaccinated. We had, as I told you, 2/3 of type 2 diabetics, 1/3 of type 1. The majority was white Caucasian, but we had substantial ethnic minorities from Africa, especially North and Black Africa. Those who became infected were usually younger. This is usually found in all studies. We had no difference in gender. We had no difference in type of diabetes, but we had a much less prevalence of white Caucasians who became infected, since ethnic minorities are known to be more at risk of becoming infected for various reasons, most of them being behavioral, probably. Now, the other characteristics of those who became infected, they had a higher BMI, which has not been well explained. Usually, the more BMI you have, the more risk of becoming infected you have. Because they were younger, the GFR was better, and they were less often taking statin, which may be related to their younger age, and a slightly less prevalence of macroangiopathy. But I will come back later on those statins, because this is the topic of the talk. So that difference in statins was seen even if we corrected for secondary or primary prevention, so they were just less often on statin. Now, when we look of those who became infected by subgroup, first the type 2 diabetics, what we found that, again, they were slightly younger by an average of 3 years. And here we have a more precise difference in statin use. So the overall statin use was 10% lower, but what was striking was the discrepancy among statins, with a much higher use of atorvastatin and a much lesser use of rosuvastatin. I haven't shown all the details, but the proportion of high-intensity statin was about the same as was what we call the statin equivalent dose, which is a normalization of any type of statin to atorvastatin equivalent. There was no difference in macro or macrovascular disease in those patients who became infected. What about the type 1 diabetics who became infected? Again, they were younger, this time by an average of 7 years, and hence their prevalence of macroangiopathy was much lower. Otherwise, there was a non-significant different use of atorvastatin, which was higher, as in type 2 diabetics, in those who became infected. Now, if we look at those who develop severe versus non-severe in the overall cohort, 2/3 diabetic, 1/3 non-diabetics, we just found everything that was reported. So being older by an average of 14 years, having type 2 diabetes, which of course is related to being older, having a higher HbA1c and a higher BMI, also a body composition with more central fat, as measured by waist circumference or percentage of visceral fat, being hypertensive and blah, blah, lower GFR. Everything was significant except for the gender difference. There was no gender difference having severe versus non-severe in these patients, which is usually less the case in non-diabetics, in whom male gender is more affected with the severe forms. And as regard macrovascular disease, there was no difference in macroangiopathy. Otherwise, look at heart failure, it just exploded, as well as atrial fibrillation. Well, all those conditions also tend to increase with age. If we look now at the type 2 who had severe versus non-severe forms, of course, the numbers are lower, so some of the significances will disappear. But what we found was, again, a difference in age, but only of 6 years on average. A less glycemic control, less good glycemic control, which I consider is probably just related to those patients being more obese and fatter. It was still significant for visceral fat. Those patients had more abdominal fat. They were more hypertensive, and their GFR was lower, which is likely a result of age. Again, heart failure was evident as a condition raising risk of severe forms, as was well known from non-diabetics. What about their levels of lipids? Well, there was no difference, no significant difference in LDL cholesterol in both the combined cohort or the only type 2 cohort, since, as I said previously, we had too few type 1 diabetics with severe forms in order to conduct a meaningful analysis. They were mostly characterized by having more atherogenic dyslipidemia. Of course, those patients with severe forms were more obese, so it was not a surprise. They had smaller LDL, a lower level of HDL cholesterol, which has been suspected to be also involved in virus transmission and infectivity. HDL may be protective against COVID infection, and they had much more triglycerides and atherogenic dyslipidemia. So that was not really a surprise based on their phenotype. What we found, which was very odd indeed, was their use of specific statins. As I told before, there was no difference in statin equivalent dose normalized to atorvastatin. They were taking 21 milligrams in the non-severe and severe form, so exactly the same amount of statin, and a non-significant difference in high-intensity statin. It was not significant, but severe form patients were even having more high-intensity statins. But what was striking us for becoming infected was the much higher use of atorvastatin in patients who developed severe forms. This is the mixed cohort type 2 plus type 1, and a much lower use of rosuvastatin prior to getting SARS-CoV-2 in those patients who had the severe forms. What about ezetimibe? Again, there was a mismatch. Ezetimibe with or without statins was much lower used in patients who developed severe forms, as was the combination of any statin plus ezetimibe. On the other hand, the ezetimibe as a monotherapy was associated with severe forms, but the numbers were extremely low. Finally, fenofibrate, which is used to treat atherogenic dyslipidemia, was unsurprisingly much more used in patients who developed severe forms, likely a result of their AD. If we take specifically the type 2 diabetics with non-severe versus severe forms, again, we found that very odd and unexpected mismatch of high-intensity statins with the severe forms. This is only type 2 diabetics now, being more than twice often more used in those with severe forms, and rosuvastatin being almost exclusively used by those patients who developed non-severe forms, with again the same standardized equivalent dose of statins, but even a higher use of high-intensity statins, which is of course atorvastatin in this case, for those patients who developed severe forms. And again, ezetimibe use was much lower in those patients who developed severe forms. So if I summarize, for becoming infected, we found that a combined type 2 plus type 1 diabetic patients cohort is less often on statin just prior to infection. Specifically by subgroups, infected type 2 diabetics are more often on atorvastatin when they become infected, and less often on rosuvastatin. The difference, if you combine both difference, is huge. In type 1 diabetics, there was no difference in statin use at the time of being infected, but still there was a non-significant higher use of atorvastatin in those patients who became infected. If we move to the severe versus non-severe COVID-19, what we saw was, despite a similar percentage of severe COVID patients being on statins compared to non-severe patients, and with the same statin equivalent dose, and a non-significant different percentage of high-intensity statins, the patients who developed severe COVIDs were more than twofold more often atorvastatin. And for those who had non-severe forms, they were more than 4 times more often taking rosuvastatin. In relative terms, it was 434%. Ezetimibe with or without statins was also much lower in use in patients who developed severe COVID was the combination of any statin plus ezetimibe. Now, I haven't put a hypothesis because the high-intensity statin proportion and standardized equivalent dose is similar. It's unlikely to be simply due to difference in statin use. Also, the difference remained when we did some other analysis, a univariate analysis, but if we look at primary versus secondary prevention patient and all those stuff, all the difference remains significant, and we at current level do not have any explanation for that. Thank you very much for your attention.
Thank you for your nice session. It was really insightful and something new which I think we came across. Any comment from our expert speaker for this observation from Dr. Michael? Dr. Buraskar, sir.
No, I quite agree with him, actually. You know, we see this kind of variation many times. And at times there are many issues while you get this phenomena in type 1 diabetes. This is not something new to us.
Okay, fine. We have a question for Dr. Tirthakan Chaudhary, if he's there. Yes, sir is here.
Yes, please.
Yeah, sir. Just for type 1 diabetic patient, for the screening of atherosclerotic cardiovascular disease, do we recommend at what duration for the coronary artery calcium score? Any guideline for that?
As I was saying, that the risk of atherosclerotic cardiovascular disease in type 1 is real, and they come quite early, and the risk is very high. Therefore, anybody over 10 years, unless you have got definitive existence of clinical manifestation of atherosclerotic cardiovascular disease. That's why I separated the group between if you are having a patient who do not have clinical evidence of ASCVD and patient who is preclinical. There are anybody over 10 years, and we do normally an altered ankle brachial pressure. And if you can do a CIMT, which is not very difficult, intima medial thickness, and if it's more than 10 years, and if he has got other evidence like microalbuminuria, so you clinically evaluate the patient. But if you tell me, when do you become proactive? Anybody who is a woman, anybody who has got it a long duration, maybe before the age of 10, and even if you do not have any symptoms, post 10 years, I would be interested in doing an intima medial thickness or coronary calcium scoring, or look clinically at least an ankle brachial pressure and look at the risk factor like lipids. I would look at microalbuminuria, look at retinopathy. And if there is the evidence of microvascular complication, that is an independent risk factor for macrovascular complication. Therefore, I would investigate. So 10 years if it is a thumb rule, but you must remember that if there's any evidence prior to that, you should look into it. But beyond 10 years, risk keeps increasing. So I would investigate preclinically. Thank you.
Thank you, sir. One question to Dr. Buraskar, sir. Just want to understand role of melatonin for the better sleep. Is it really, or what is the role of melatonin as a drug for the better sleep? Because we have seen quite across few prescription from our neuro colleagues also. So what's your take on for this? And
I prescribe melatonin very routinely. There is a lot of evidence, I think during COVID time, the altered sleep pattern, they particularly said that melatonin helps in COVID-related sleep disturbances. And we start with 0.3 milligram, 3 milligram melatonin. You can go up to 6 milligram. It has very little effect on the respiratory depression center. So melatonin is quite safe. My point is that there are phases of sleep of N1, N2, N3. Now, out of which N1 is very important when a patient is about to fall asleep. Now, if you want to cut it short, how to reduce N1? There are drugs for that. Melatonin helps there. Sustaining the sleep of N2, N3 pattern, the drug of choice is Ativan or lorazepam. But it may have a offshoot phenomena, means it may act little longer, and then a person may have a mild hangover effect. That effect is not seen in melatonin. Melatonin you can go up to 6 milligram also, no problem. And it is reasonably safe drug. I give it to many of my patients. They don't have any complaint about melatonin. It doesn't cause dryness of mouth. It doesn't cause any cognitive dysfunction next day. It has got no effect on the dreams. At least nobody has complained of bad dreams. And it has got no definite effect on altered breathing pattern. The sleep apnea doesn't become worse with melatonin. So I have a good experience with melatonin.
Thank you. Thank you, sir. Now we do not have further questions. So would like to thanks all our respected speakers and audience for having here and sharing their knowledge. Thank you all, and would like to hand over the session to the organizer for further. Thank you.
Thank you very much.
Thank you.
Thank you, sir.